Bruce Hubbard. I'm the president of New York City Cognitive Behavior Therapy Association, and I am thrilled tonight to introduce our speaker, Dr. Michael Perelman. Michael's titles and accomplishments are too numerous to list here, but to say just a few: he is clinical professor emeritus at Weill Cornell Medicine. He's co-director of the Human Sexuality Program at New York Presbyterian Hospital. Michael is the founder of the Math Education and Research Foundation, which educates healthcare providers about biopsychosocial, behavioral, and cultural approaches to the diagnosis and treatment of sexual disorders. Dr. Perelman has served on several professional organizations, boards of directors, and is a past president of the Society for Sex Therapy and Research. He's co-editor of the book Management of Sexual Dysfunction in Men and Women. He's published over 60 peer-reviewed articles, and tonight his topic is the sexual tipping point model, diagnosing and treating sexual disorders. So I give it over to Michael Perelman.
Thank you, Bruce. How's the volume on this? It got me lavalier. Can people hear in the back? Everything's okay? Great. So, as you said, Michael Perelman, and we're going to talk tonight. Here's my disclosures, first of all, those of you who pay attention to things like this. I have consulted to some of the pharmaceutical companies that develop the various drugs you see advertised on television. At some level, that's influenced some of my thinking, and we'll talk more about that momentarily. I've actually waited 40 years for this invitation from you guys. I know your society isn't quite that old, but 40 years ago in Principles and Practice of Sex Therapy, I coined the phrase a cognitive behavioral model for sex therapy. And so I've been waiting to give this talk for a really long time, so thank you for inviting me. The agenda tonight, we're going to talk about the sexual tipping point and how it's an integrated approach to treating male and female sexual dysfunction. We'll talk about taking a sex status exam. I'm sorry? I think everything's fine. Thank you very much. Anybody need anything from this gentleman before he takes off? Okay. So we'll talk about taking a sex status and what that means and how to use it within an STP framework. And then I'm going to discuss a sexual dysfunction case using a cognitive behavioral sex therapy model, just so that you get a sense of how I actually treat people as opposed to the more theoretical aspects of this. Sex therapists really distinguish ourselves by asking about sex in minute detail while maintaining rapport with the patient. So what guides my questions? The answer is a sexual tipping point model. The STP is an easy way to depict both the mental and physical elements of sexual function and dysfunction for both men and women. And again, it's an integrated treatment approach. And by that I mean you're integrating a number of different theoretical backgrounds as well as the appropriate use of pharmaceuticals when and where needed. So why is this important? And the answer is because sex is always mental and physical. It's best understood as an endpoint representing the cumulative interaction of every cognitive, behavioral, social, and cultural factor, not merely the biological determinants. So especially when I'm speaking to our physicians here, I try and emphasize how it's not just biology, and that's really the focus of the foundation that I started as well. Now, this isn't my idea. You know, Rene Descartes was talking about this a long time before I was even born. But sex is always mental and physical. The mind can turn you on, and the mind can turn you off. The body can turn you on, and the body can turn you off. Positive mental and physical factors increase sexual response. Negative mental and physical factors inhibit sexual response. So biopsychosocial dual control models offer explanation for such interactions. John Bancroft and his Kinsey colleagues described what was the most well-known of these dual control models. But Helen Capulan, who had been my mentor here at Cornell, was the first to publish a dual control psychosomatic model of sexual motivation. Helen was an artist. She emigrated from Vienna through Paris, and she spent a year in Paris studying art. So this is a little sketch that she did in her last book in 1995, where she's talking about sexual inciters and sexual suppressors. So I sort of took that idea, along with other people. There's a number of sexual response models. Mine's not the only one. But Jim Faust, who's a really, who knows who Jim Faust is? Anybody? So Jim Faust is a rat researcher in Canada, and he's really an amazing guy. He does all these physiological studies on rats. He'll take a female rat and a little teeny paintbrush, and he'll stimulate her clitoris and record the changes in her brain while he's doing that. I mean, he's really done some amazing stuff. So he does a lot of the preclinical work for almost all the drug companies that are producing sexual medicine drugs, because they need to have some sense, is there any kind of marker that says this is likely to work? So he really knows a lot about neurobiology, the brain, how that impacts sex. So he was nice enough to describe the STP model in his classic 2009, and this would be a great article to pick up if you want to walk away with one thing from this lecture. A 2009 JSM article on the neurobiology of sexual desire. So he used this sexual tipping point model as a basis to explain what was going on. In fact, you'll see another one of his slides interspersed later on in the presentation. So I really valued the shout out from Jim that he was like calling attention to my model and this very important paper that he wrote. But he was incorrect. The STP model, while concordant with the dual control models described by Bancroft, Jansen, Graham, and others, it actually doesn't quite capture what really goes on. Initially, I did think that the STP illustrated factors that characterize sex as the net sum of billions of different microswitches, right? Now I realize that on-off switches really fail to capture the full range of biological and psychosocial variability that is sex. Now, why? STP factors are continuous, not categorical. I mean, this is something I'm sure you've discussed both in your own practices, within, for all you know, you may have had a presentation just on this. It'd be an interesting topic. All the diagnostic classification systems that the psychiatrists use are based on creating these categories. And yet we know there's huge variation amongst humans, and these things tend to be more variable. They're more continuous than they are categorical. So a binary model is really inadequate to describe what's going on. The proportional net impact of all the factors is really what determines the variability that you see both within and between individuals. Someone like yourself, Bruce, if you're having a tough day and you go home and you want to have a sexual experience, it really depends on what's going to happen once you get there. If the kids are crying and everybody's beating on you right away and it's a problem, the likelihood that you're going to want to do that is not very high. If you get the flu, you have the exact same genetics, the exact same epigenetics, and yet your sexual response will be very, very different that moment, that day, than the next day when you're feeling better and you decide to take a day off from work and go have a good time. So these things are very variable, not just between different people, but within every individual. And it's the net summation of all this that determines what's going on at any moment in time. So you have physical factors, whether you're talking about anatomy, endocrine systems, neurology, etc. They're first decided by genetics and epigenetics. For instance, receptor site sensitivity or strength. And later, aging, toxins, illness, pharmaceuticals can all contribute to changing biology, deteriorating performance. Fully describing all the mental factors, the psychosocial, behavioral, and cultural ones, is really beyond the scope of this lecture. You're all psychologists, you all get the idea how many different things might be impacted in this area. So what's the problem here? The problem is that our scientific models borrow from the technology of the day. Now that's as true today when considering computer networks as the switchboard analogies of the 1950s or 1960s. Dual control models derive from the binary algorithms developed for silicon computer chips. Our brains are carbon-based systems. This silicon-carbon gulf is very similar to the physics conundrum, Is it a particle or is it a wave when it comes to light? And many people think it's both. The STP is really closer to a variable nano switch. Think dimmer, right? Think a dimmer switch. Let's see. Oops. So we got these dimmer switches, right? Imagine that each of the small circles inside these containers symbolize a factor which acts as a dimmer or a variable nanoswitch, which can still be distilled down net into hot or not. The setting on each factor's dimmer contributes to the STP displayed on the scale, and it's going to vary between excitation to inhibition. So that dimmer analogy allows the STP to illustrate all the intra and inter-individual variability characterizing sexual response. You know, is she hot or not? Is she a cougar or a kitty cat? Now, there can be changes, though, in these factors' polarization and valence. What do I mean by that? Mental. So, what used to be a wonderful caress, if there was pressure across the neck, all of a sudden, after someone's been raped, that same touch elicits nausea, a complete shutdown response, if not just sort of like panicky fleeing at that moment. So we know that mental aspects of things can influence what goes on. It's not very complicated, but to try and find a model that can account for that is where this gets a little bit interesting. So what about physical? So aging, illness will inhibit what was once a robust response. And I'll bring this around to some clinical material so you'll see how this fits. But I want you to be able to have a mental picture in your mind that's really quite simple in some ways to understand any sexual issue that's ever brought to your attention by a patient. Now, drugs are side effects. You and I were just talking, you mentioned that you referred a patient to our group, and after a 6-month treatment that you're having some difficulty and struggling with, the therapist seemed to be able, the sex therapist seemed to be able to get the woman functioning fairly quickly. But as you correctly noted, all she did was switch the patient from being on a strong high-level SSRI to Wellbutrin, which has less sexual side effects. And that immediately made a difference. So we know that drugs can be bidirectional. You can use Viagra and be able to get an erection. And you can take an antidepressant that is a little bit too overdosed for you, and you completely inhibit sexual response. What about fetish? Neutral objects can become eroticized, like Mrs. Robinson's stockings. So it's a way of modeling everything that you're going to run across. Now Einstein said everything should be made as simple as possible, but not simpler. And this STP stuff is starting to sound a little more complicated, even though I keep saying it's easy. So let me see if I can make it simpler. There are 2 pairs of interconnected containers, mental and physical, which hold all known factors regulating sex. Each factor, that dimmer switch, and there's billions of them, each factor's setting varies as to its degree of hot or not, sex positive or sex negative. So I mentioned Jim Faust before. So the slide on your left is talking about how dopamine and noradrenaline can act as positive sexual stimulants on the brain. So all these various drugs that affect desire, which is a central phenomenon as opposed to erection or lubrication, which is a vasoactive phenomenon in the genitalia. Here you've got 2 neurotransmitters that really turn things on. And yet serotonin, the primary component of the antidepressant that Bruce's patient was taking, can inhibit or turn us off. So this can go either way. And then of course, the mind. So on the left, you've got sex-positive thoughts. This is a list compiled by Cindy Meston out at the University of Texas. She's got a wonderful sexual physiological lab. And it talks about all the reasons people have sex. And some of them seem sexual and some of them seem not so sexual at all. But this is what goes on in people's minds. And then reciprocally, you can have negative thoughts which are going to interfere with your ability to function. And what about relationship factors as well, of course? And when I say relationship, we could be talking about like a one-night stand or a 50-year marriage. It's how you feel about that person at that moment in time. That's what's going to impact your sexuality at that time. Now, some factors may be neutral. They really, you know, it's there, it's going to bother somebody, but it's not going to necessarily make a difference for someone else. And importantly, some factors are unknown. I wanted the model to be able to account for things that we haven't discovered yet. And yet, you know, for instance, like we were talking about serotonin a few minutes ago. So there's a lot of subtypes of serotonin, and they're going to have different impacts. And while as psychologists we're primarily concerned with the mind, it's critical to also understand the way the body is going to influence both behavior, emotion, cognition, etc. And yet the bottom line with this, getting back, trying to make it simple, is, you know, is she hot? Is it neutral? Is it not? Isn't it happening? And the idea is to try and figure out why. So what's the takeaway from all this? Number one, recognize that sexual dysfunction is always determined by biopsychosocial, behavioral, and cultural factors. This one slide says it all. Second, an individual's sexual function at any moment in time is determined by the net sum of those factors. Third, identify the key interfering factor as the initial treatment target. Fourth, inspire hope by explaining the STP formulation and the initial treatment targets to the patient. I tell them, you know, here's what we figured out, here's what we're going to do, and here's how it's going to happen. It can be that concrete, and yet with this case that I'll describe momentarily, you'll understand some of the subtlety and nuance that's involved. Once the treatment targets are identified, interventions can be timed based on whether a factor is predisposing, you know, is it constitutional, a prior life experience, that could be mental or physical. Precipitating, did something happen? You know, we were just talking about rape a few minutes ago. All of a sudden there's this horrific change in the timeline. Or maintaining the dysfunction. You know, ruminative thoughts about performance are going to maintain a sexual dysfunction. One of the problems, we see a lot of quote-unquote New Year's Eve impotence. You know, young men, they get themselves too drunk, they go and they have sex, they're not able to function. Then they start like thinking about it. I wonder if it's going to work the next time. That's no longer a sexy thought. That's going to begin to interfere with the positive fantasy that needs to take place. And by fantasy, I don't necessarily mean you're thinking about some porn star. You could just be thinking about something that's sexually a positive cognition, a positive sexual cognition. And if you don't have that, you're not going to have a sexual experience, although that's age-related as well. We'll talk about that in just a second. So you explain this to the patient, and not only does this provide hope, but the very explanation begins a process of cognitive restructuring, which is all of your bailiwick. So how do I identify these factors? The answer is I get a sex status. Now that's not a questionnaire, it's not a test, it's just a history-taking method. How do we do that? We ask very focused questions, stepping back and then probing again, depending on the patient's comfort with the inquiry. So what questions? I try and keep an F word in mind for myself so that I'm able to know exactly, you know, what questions I want to ask. Actually, not that one. Some of you have a dirty mind. I'm talking about friction, fantasy, frequency, and feelings. Those are the things you need to find out about, and how they're either precipitating or maintaining what's going on. So, like any functional analysis that you might be doing within your own practice, you want to ask, listen, clarify. Tell me what you mean by premature ejaculation, or whatever the chief complaint is. What do you think is causing the problem? But for me, the best single question you can ask is tell me about your last sexual experience. That gives me a video picture in my mind that helps me identify all the immediate and remote causes. I'll give you an example. About 20 years ago, there was a patient here at Cornell an Orthodox Jewish young man who had recently married. They wanted to have a baby, and the urologist electroejaculated him to produce a semen sample, and then she was artificially inseminated because they said they didn't know how to have sex together. So they had their first child. A couple of years go by. They come back, and they want to repeat the procedure. Fortunately, one of the urologists said, like, why don't you let him go see Perelman for at least 1 or 2 visits and see what's going on? I mean, I wish all cases were this easy. So this young couple comes to my office, and just like I said, I ask everybody, tell me about your last sexual experience. So they look at each other like I'm crazy and I'm being rude, and they start talking Yiddish, and I have no idea what they're saying. And then the guy says to me, you know, just because I'm Jewish doesn't mean we don't do it the normal way. And I said, no, I understand, I'm Jewish too, you know, like, I ask everybody this question. And he goes, yeah, but we're Jewish, he says with emphasis, like, you know, we're not relating here. So I explained again that it's really important for me to understand what's going on if I'm going to be able to help you. Tell me about your last sexual experience. So he tells me that he goes inside her, and then he waits. So I said, well, you know, that's a very good way of delaying your ejaculation. We teach that to men who have premature ejaculation. I said, what happens then? And they talk more Yiddish to each other. And then they look at me, again, like I'm some kind of moron. And they go, well, we wait some more. I said, and then? We wait some more. And then? He said, well, it falls out, and then we try again the next day. I said, do you ever move? And you see the light bulb go on over their head. Now this couple has 8 children, they live in California, and my wife who's in the back will tell you every year they send us matzah. Dear Dr. Perelman, you should have like a very happy Passover with your family. So none of these urologists, none of the gynecologists, none of the reproductive medicine specialists, now this is 20 years ago, believe me, they do it today, had asked these people how they had sex. Their orthodox demeanor, their customs, their style, their clothing, made them very, very uncomfortable. With our younger trainees, in fact, we see the same thing when they're treating, you know, people I think my age, you know, kind of grandparents, where they just don't feel comfortable asking the sexual questions. And if you don't get the details, you're not going to be able to help people. So what's critical? You need to make sure that the person is actually having a sexual problem. You know, if someone from my program goes on television and does a lecture, all of a sudden we get all these like referrals of people with all kinds of crazy stuff because sex sells and it becomes a finding ground for all kinds of patients. So people will use that as a reason to come in for help. As many people who avoid coming for help with sex because they find it embarrassing and shameful, there's other people who just will call you and want to come in. So is there a sexual problem? What are the underlying organic and psychosocial factors? What are the immediate maintaining psychosocial factors? Current cognitions, emotions, behaviors that are driving what's going on. Any deeper issues that you need to understand, and most importantly, are there any underlying psychosocial or organic issues that must be treated first before you approach dealing with the sex? If somebody has a serious addiction, alcoholism, a cocaine problem, a heroin problem, even though a lot of their drug usage may be related to sexual anxiety, because the only way they can have sex is when they're high, you really need to treat the addiction before you can start dealing with the sexual problem. And yet, if you don't deal with the sexual problem, the likelihood of relapse actually becomes very, very high. Let me give you a case. Try and make this a little bit more personal to what you might be doing in your own work. So Jack and Jill, 59 and 54. Initially referred by his urologist, Jack was seen alone at first. He complained of a progressively severe erectile dysfunction. Sildenafil had initially helped him gain an erection, but it no longer worked. The urologist had noted that his hormones, his physiology, everything was normal, and decided, you know, maybe it's better to make a sex therapy referral. Jack came in, he reported to me, the Viagra's not working at all. Even if I get inside, I lose it. He reported avoiding sex, afraid of disappointing himself and Jill with her erections. After all, who wants to do what they don't do well? Now, while very distressed about his ED, Jack was eager to restore what he described as a great sexual relationship between himself and Jill. They had, Jill was his wife of 20 years, and he described it as a wonderful marriage. So this is still the first section. The sex status revealed, I asked him about the last sexual experience, asked him, and it revealed a lack of any direct foreplay for Jack beyond kissing and cuddling. As he concentrated on Jill, he quipped, you know, I never needed it before. It doesn't really occur to me to do something for myself. I always am able to get an erection, but no longer. He was unable to keep any erotic thoughts in his mind once he attempted coitus, even when he had a Viagra-assisted erection. It just falls out. My wife is unhappy and questions if I'm still attracted to her. I love her, she still looks great. It's just not like it was. So I explained about the normal need for more direct sexy stimulation, friction, and fantasy as one ages. You know, if you're a 15-year-old boy and you're walking along the beach, you know, and some beautiful girl gets hit by a wave and her top comes down a little bit and you're seeing a little breast, you'll probably get an erection and be mortified, walk into the water, hoping that, you know, like George Costanza, the shrinkage, the cold will somehow like reduce things for you. That doesn't happen to a 51-year-old man. You're a 15-year-old boy and you're sitting on a bus and it vibrates. You might be embarrassed that you start getting an erection. It doesn't happen to a 51-year-old man. So there's age-related changes. Remember we were talking about the dimmer and how the valence can switch, the intensity can switch. There's age-related changes that you need to, A, be knowledgeable about, and then find a way, without humiliating the patient, of helping them understand that, you know, you wear glasses, I don't feel like I'm blind, but in reality, I can't see very well without them, and I wouldn't be able to look at my notes here. So you try and help people accept this, and that's part of the cognitive restructuring. So I suggested you try masturbating while taking the Viagra and using erotica. Now, in reality, I didn't think he really needed the Viagra. I thought it was gratuitous that, that it had been prescribed for him initially in terms of his biological need. But what it does is help someone be able to maintain their erection, even in the face of thoughts that might be periodically negative. The reason for that, maybe you know, maybe you don't, all these drugs, Viagra, Levitra, Cialis, they work by keeping you from losing your erection. They don't actually give you an erection. They're not vasoactive. They don't drive blood into the penis or into the vagina for lubrication. Instead, they inhibit the flow out. So if you think of a bathtub analogy, you know how Cialis has, I always have the bathtubs? Here's part of the reason why. Mostly it's iconic, and they saw that people got annoyed by it, but that helped them remember the drug, so they continued to use it. But the bathtub analogy has to do with this. You can turn the water on, and if you get a lot of water coming in, the bathtub fills up, if you've got the rubber stopper in the bottom. If you pull out the rubber stopper and you shove in a bunch of, like a box of Kleenex, if there's enough pressure coming in, the bathtub still fills up. You pull out the Kleenex, it drains out. So anxiety, fear, or emotion cause a hormonal reaction that causes the bathtub to drain, that causes the penis to drain blood, and that's the mechanism by which scary thoughts result in diminished sexual capacity. So what the Viagra, Levitra, or Cialis do is it's like taking that Kleenex, shoving it in the bathtub drain, and as long as you're having some sexual thoughts, which is why I told him to watch erotica. Now, he's really in love with his wife, he finds her attractive, but the reason for the erotica was to distract him from worrying about all this other stuff that was interfering, in the hopes that once he had some better experiences, it would boost his confidence. So what happens? He started feeling more confident just as we were talking. He seemed hopeful, optimistic, and he indicated that Jill was eager to have sex with him and reportedly wanted to participate in the sex therapy. I mean, it's usually a good idea to see couples. So we scheduled a follow-up couples appointment with an option for Jill to have some individual time with me as well. Because sometimes you find out things seeing one person that you're not going to find out when they're together with their spouse. The whole issue of treatment strategies, of dealing with secrets, of dealing with information that you get in an individual session versus a conjoined session, it's really a topic for another lecture. But anyway, the next session, Jack reports good news and bad. Masturbating with a Viagra worked well, but a few days later we tried to have sex. I got an erection having used Viagra, but it still fell out almost immediately. So if you've got enough anxiety and enough negative thoughts, just like if there's not a lot of water coming into the tub and the Kleenex starts getting a little soaked and starts losing its absorbing capacity, you end up with a reduction. And once that happens, so many guys, when they feel their erection getting smaller, will just feel embarrassed, ashamed, which makes it smaller still. And most of them will actually, if you get the detail, most of them actually pull out, they don't really fall out. So they're actually pulling out with a partial erection because they don't know how to move in a way to enhance their erection and how to think in a way to arouse themselves and get themselves more erect. Anyway, back to basics, I asked them to describe their last sexual experience in detail. Jill interrupts Jack just as he begins to speak. Per my initial invite, Jill asked if she could speak with me alone. Jack left the room temporarily. Jill described her desire to be with Jack, mentioning how the foreplay was pleasing and satisfactory for her. But then she discussed their coital failures. She grimaced. She cried. I want sex because it used to be so good. Sex hurts now. My orgasms are muted and I have no real desire left. It's been like this since my menopause began when I went off the pill 2 years ago. She said, I feel like just these dead-end sensations. Jill correctly attributed some of their problems to mutual aging. She reported very high intimacy with her husband and love. But was so confused about her sex problems, my gynecologist says it's normal to stop at our age. I tried using the lube she suggested. He felt less, which makes sense, by the way, right? You're reducing friction. He felt less, it still hurt. She also revealed some important historical information, and I'll give you those details in a moment. Jack rejoined us and self-consciously admitted he was aware that it hurt. He felt guilty as they never really talked explicitly about her pain. But he'd been convinced that his ED was the problem, that if he had a good enough erection, everything would be fine. And she'd gone along with that theory. So you have a couple of had age-related changes, and the real issue is they had no real help adjusting to what happened to them. So what was my case formulation? In terms of immediate causes, which is the first thing I'm going to take a look at, there was insufficient stimulation. The foreplay for him was inadequate, and his cognitions are non-sexual. He never needed it before, and he doesn't know how to get it now. So he's saying, I'm not hard enough, I'm hurting her. Pretty negative thought. What about, I said you need to rule out substance abuse. They're only having one glass of wine periodically with dinner. If anything, I think the glass of wine was helping by reducing some of their anxiety. Well, what about her physical pain? Clearly, a pelvic exam and some labs would be needed. Mid-level causes of factors. From a partner's sexual script point of view, as a couple, they were really trying to get back to something that they're not going to be able to anymore, when sex was completely automatic and spontaneous, and they haven't developed a new script that will work for them. So what was my treatment plan? I recommended, in private practice, you've got a lot of flexibility that you don't always have if you're in a clinical setting like the institution here. But I recommended 90-minute sessions in 3 parts. 2 individual sessions, and I always had her go first. You can ask me about why later. And 1 conjoint visit subsequently. And they would wait in the waiting room and then come into my office. They'd be there for 90 minutes. Now, I'll often work with clients' existing physicians, but Jill and I agreed together she really needed a new gynecologist, or at least a second opinion. They agreed to a no intercourse rule because I really wanted to take the pressure off them completely. This is something most of you are aware of, kind of typical sex therapy maneuver. This is sort of paradoxically, you tell them to not have sex and you secretly hope that they will. So they agreed to that, and I told them the outer course was okay. One of the things you see with novice sex therapists is they're trying to sell patients on, well, you don't have to have intercourse, or, it's patriarchal, there's a lot of ways to have sex, you don't have to do this. People know what they want, and I think you're doing them a disservice if you're trying to sell them on something that they don't want. I think it's one thing to expand their horizons and get them to see there's many different paths they could take, and it's all positive. But that's different than like, why do you want to have intercourse? You shouldn't do that, and you really don't want to go there. I recommended that Jack masturbate to increase his awareness of likes and dislikes. And I had in mind to wean Jack from Viagra over the course of treatment. So what did the new gynecologist say? She had severe vulvovaginal atrophy. The vagina emitted only 1 finger, with adhesions between her vaginal walls. This was going no place fast. So the gynecologist recommended topical intravaginal estradiol cream nightly for 2 weeks, then reduce it to 3 times a week. And once she was adequately estrogenized, to begin using soft dilators to remodel the vagina, to get her comfortable with the feeling of something inside her once again. The gynecologist supporting what I had said, let's avoid vaginal sex until dilation is pain-free, which was guesstimated at 4 to 6 weeks. Now, a little commentary on this. The individual sessions really gave me a deeper history-taking opportunity. You know, it was clear to me what the immediate causes were, but there was just something like a little amiss here, and you have to trust your instincts. One of the things that he reported was that he was also suffering from a non-coitable delayed ejaculation, DE. What that means is he could masturbate to orgasm, he could have an orgasm during intercourse, but if she gave him oral sex or manual stimulation, he was unable to come, and that had been a lifelong issue for him. You'll figure out why momentarily. So he was to cease masturbating at that point to orgasm. I told him it was fine if he's in the shower and he's washing himself, that he wants to touch himself. It actually would be helpful to understand what are the more sensitive parts for him, what part of his body does he enjoy. But I didn't want him to have an orgasm, because it's actually the orgasm that makes you refractory to your ability to obtain and sustain another erection in a shorter period of time. And as you age, that period of time gets longer and longer. So for a 20-year-old, it may be 20 minutes, but for an 80-year-old, it could be 2 weeks. So I mentioned about the individual sessions. Part of what I did was to assess both the source of anxiety and depression, because I just felt something was going on, and the lack of treatment options offered by her gynecologist, and the mutual misinformation they received had created some despair, especially for her. She was involved in a conservatorship for a disabled brother, lots of stress. The partner issues were still an issue, being stuck on the past sexual script, which had been so automatic and easy. But some really deeper issues emerged as well. She had a childhood sexual abuse history by her alcoholic father that began at age 6. While no violence occurred in the home, the father intimidated everyone and had affairs openly, and was just loud and obnoxious around the house, reportedly. The abuse to her included manual stimulation, oral stimulation, her to him, coitus as a 6-year-old child, and anal stimulation to the point of ejaculation. Then he would require her to go to the bathroom, get towels and washcloths, and clean him. It stopped when her parents divorced immediately. After, at age 13, she revealed the abuse to her guidance counselor, just during the consultation about her going away to high school. The guidance counselor reported it to police. The father was prosecuted, the parents divorced. And as I'm trying to absorb all this that she's saying, she goes, by the way, did he mention his mom's suicide to you when you saw him individually last week? So I'm thinking, I may need to reconceptualize and reformulate what I'm going to be doing. So do these deeper causes or factors, his mom's suicide, his guilt, his subsequent abandonment fears, as you can imagine, if your mother commits suicide when you're 15 years old, her childhood sexual abuse by her father, are these relevant? Are they going to make a difference to treatment? How do you impact the timing of your interventions? And I would say no and yes, not necessarily. Why? And any guesses at that? So why wouldn't I be concerned necessarily about somebody who had been subjected to this kind of severe sexual abuse? Any ideas?
They had a 20-year history of good sex.
Exactly. So for whatever reason, some people, of course, are damaged by something like this permanently, whereas other people are more resilient. So what happened here was this horrific stuff happens, and if she has this adult history, they didn't get married until she was 40, of good sexual functioning with other men as well as with her husband, and then this 15, 20-year pleasant history. I guess they were married 12 years at that time. Just very, very good history. The yes part of this, though, not so simple, is that her pain was triggering abuse memories for her. So it becomes a recapitulation for her. And I was concerned that this risked a contagious communication to her husband. So all of a sudden, you know, Mr. Nice Guy is going to turn into Daddy, who is a creep. And she's a very insightful woman, and she was aware of this herself, and it's part of why she pushed to be able to participate in therapy. She wanted to be able to discuss this. Now, what about on his side? His oversensitivity to women generally, which really came out of these abandonment fears, so he was very conflict avoidant. And for Jill specifically, was normally a positive for them given her abuse history. She really needed to be in control for all the obvious reasons. There's so many things. It made Jill feel safe and control, especially during sex. But of course, at this point, now that he's older, it's playing havoc with his erectile and orgasmic capacity. Because he's so worried about her, he's not allowing himself to get aroused. So I updated my treatment plan. I spoke with a new gynecologist regarding Jill's risk of greater anxiety and depression caused by the stress of treatment. She said, you know, it's pretty tough on me talking about this stuff and thinking about it again. So the gynecologist prescribed 5 milligrams of Lexapro, and we put that in as a little bit of a safety net. As you know, that's a very low dose. So her vagina gradually improved with the estradiol cream. She began and continued using the dilators 3 times a week, using almond oil that they used to use when they were younger and gave each other massages. And they decided that, you know, you try and find some things in their past that they can connect to that would work in the current situation. You know, so many of us engage in greater amounts of foreplay early in a relationship than you do, you know, 20, 30 years later. So we got them using this, you know, almond oil to give each other massages, and she actually was orgasmic when he would touch her. If you remember, he doesn't know how to come that way yet. Enhancement techniques were discussed during the next few sessions. As their sex life improved, so did their mood and their confidence. Time was spent helping Jill integrate positive feelings about herself by emphasizing her historical resilience and coping skills. Exactly what Bruce is talking about. That if she was able to function before, I asked her specifically, you know, what went on in your mind that allowed you to compartmentalize one situation and allow yourself to fully enjoy another? And how might we apply that to what's going on now? She was helped with other family of origin stresses. I was trying to just reduce the overall pressure by giving her some guidance on how to manage her brother. Jack was given assistance with some stress he had at work. And there was continued cognitive restructuring throughout all the sessions. Now at the 9th visit, they asked for the conjoined session first. You know, a little change in the plan here. And I was like wondering what was going on. And sheepishly, they reported having had successful unauthorized intercourse with mutual orgasms. Hers were still muted and different, but they were delighted and very pleased with their progress. But they reported that since sex was so good, they tried it again the next day. No surprise, she was tender, and while he was able to erect an orgasm, she experienced pain again and expressed concern for her future. Am I ever going to have a sex life again? So a little reassurance in sex education about aging. You don't have to do it every day. Foreplay and lubricants were offered. I asked Jill to self-explore with the 3rd and 4th dilator, and taking the history of what was going on, it turned out that she started feeling a little sexy and had an orgasm using the 2nd dilator, and figured, like, why should I bother using the bigger ones before attempting intercourse again? He was told to stop masturbating completely now. So now I don't want him touching himself. I don't want him having an orgasm. If you want to have an orgasm, Jack, it's got to be with her. And so I'll vacillate between trying to be, you know, sort of sympathetic and allow them to direct the treatment, and coming on very directively at times when necessary. Sort of Kaplan used to talk about sort of an accelerator and a brake model for sex therapy. So the sessions continued over the next 2 weeks, and he was finally able to orgasm. In fact, he told me he felt like he was going to burst. And this is what's great about sex therapy. I've got Mother Nature on my side. You have a guy who's masturbating 3 times a week. If you tell him you're not allowed to masturbate at all, he feels like he's going to explode. So now it doesn't take a particularly skilled courtesan of a wife to be able to stimulate him manually and have him have this ejaculation, which was nice. It was kind of a virginal experience. The first time he comes in response to a woman, it's with his wife. She feels great, he feels great, all very positive. That same week, because she was very turned on to see her turn him on, That same week, she had a fantasy about sex with Jack twice while using the fourth dilator, and it's pretty big. She had orgasms each time. The next weekend, returning home from dinner, Jill initiated and they had successful intercourse with mutual synchronous orgasms. This occurred again the following week. So treatment was terminated after 3 longer spaced briefer follow-up sessions. So I reduced it from 90 minutes down to an hour and 45 minutes. Rather than weekly, we saw them like in 3 weeks, and then I saw them again in 5 weeks, and kind of weaned them off the therapy. Now, Jill will consider androgen or fulvestrant in the future if needed. Androgen meaning testosterone. Well, many women have a lower level of testosterone in response to menopause, so sometimes you need to augment their hormonal levels in order for them to feel desire again. But we also know she's on the Lexapro, so I don't really know to what extent that may be muting her orgasm. And until we are able to wean her off the Lexapro, I'll see them again 6 months later. Until we wean her off that, we don't really know if you might want to use any other kind of pharmacotherapy to assist the treatment, and or if they're having such a good time together, over time it just may improve, and you want to give them an opportunity for that to happen. So for now, they just wanted to enjoy their renewed sexual intimacy. So that's that case. Before I stop, and be happy to take some cases from all of you, and if you have any questions about your own patient population, I want to just show you how you can use this model to depict a variety of different kinds of sexual disorders. For instance, here we've got, some really big fat guys suffering from the metabolic syndrome, which we know goes along with high blood pressure, diabetes, diminished sexual capacity, sleep apnea. I mean, basically these guys are all a mess. There must be some kind of Overeaters Anonymous meeting. I'm not sure what they're doing, but they got a real problem. A typical primary care therapist will take will typically, Fat David's doctor will give him a PD-5. You go in to see a urologist, I can't get it up anymore, what should I do? And they just write him a script. They don't really talk with him very much. So one of the things we try and teach physicians to do is to do more interviewing, more counseling as part of the process. But they'll give them Viagra, Levitra, Cialis. Now, this will work 50% of the time. But, that's not bad. But it's also not great, because 50% of the time it doesn't work. So what do you do? This is where you guys come in. Because by integrating a treatment with these various pharmaceuticals and working along with the physician, you can provide some counseling. You can advise them on, all of a sudden, Big David is now looking like muscular David, on doing more exercise, on some weight control, maybe a little luck, a little spiritualism, the hand of God, or maybe some new drug comes along that works a little bit better, so we don't have to work quite as hard. But the point I want to make is that there's a role for all of us, regardless of how much you see on television. Ask your doctor, get this prescription, and you'll be able to be cured. We can work together with them, and I think it's a very, very important area for psychology to be moving more and more into health psychology. Here's another situation where where the etiology is a patient suffering from secondary ED after being humiliated by his ex-wife. So I'm just sort of modeling how this might work. And I said that I wanted a model that would help us deal with the future as well. So if we think that somebody discovers what the genetic markers are for a very slow intravaginal ejaculatory latency time or premature ejaculation, so that somebody identifies one of these question marks and all of a sudden we've got it figured out, it probably would be like Marcel Waldinger or Chris McMahon. They're the big PE guys, one's in Australia, one's in the Netherlands. And they discover something that can be done, or they discover something else that can be changed from inhibiting to more positive. But even if they're able to do that, and I promise you there's going to be new drugs coming out, there's a lot in the pipeline both for men and women. And you've got stem cell research, a variety of work on neurotransmitters, all these new things in development. We don't even know some of the things that may be inhibiting sexuality. But what we can do is this sort of integrated counseling that really makes a difference. And you'll find your patients are so grateful. Sex is pretty important to many, many people, especially if you're not having it, to be able to do it once again. So recapturing that ability becomes quite profound. So I think of this, and I'm doing some research, as transdisciplinary research, where basically we're collaborating, but it's different than, you know, sort of a multidisciplinary team where you're just talking at each other. And it's even a little bit different than an integrated team where, like, the urologist sent the patient to me, the sex therapist, and I'm taking care of it, we talk a little bit with each other. Transdisciplinary is something that's happening in cancer research a lot now, where you've got people from different professions of origin coming together using a common language and understanding of particular problems, so that essentially everybody's on the same page and you have a highly integrated treatment. So that's what I'm most interested in now. And if anybody wants any of my papers, it's all available free at mapedfund.org, the foundation. Under the resources section, you know, you don't have to bother like Googling me to look it up, just go to that. And under resources, you can download any of the publications or presentations that I've ever made. One thing that's particularly interesting, I wrote a history of sexual medicine for the American Psychological Association, and that's up there too, and it's available as a free download. So anyway, that's my talk. Thank you very much. I'm happy to take some questions if you have some. All the mics in front of you just need activation, and then you'll be into the PA system, and you can ask your question if you have something. Anybody? Yes?
I have clients who complain mostly that they're in relationships. You know, they love the person, they get along, but somehow they have a longing for some bigger sexual experience.
Sure.
And I give them the usual spiel about how desire varies with novelty and all these factors, and but it doesn't seem satisfactory.
Have you seen them both individually and conjointly?
No, sometimes I do, but they often come to me for other issues, so they don't come specifically for sexual issues. But in the treatment, it emerges that their relationship is not quite what they want it to be, and they're wondering if they're meant to stay with this person after 4 or 5 years of being with someone, because of the sexual interest is not as great, and they have a fantasy, or they meet someone in the office who turns them on, and
Sure.
they're wondering, should they leave this old relationship?
So that one sounds a little bit like somebody's an individual patient
Yes.
in your office,
Yes.
and they're going through their feelings about the current relationship. So let's role play for a minute. So I would just ask, you know, it sounds like this is something that's really on your mind. I'm glad that I've been able to learn so much about you, but I really don't know that much about your sexual history and your current sexual experience. Tell me a little bit about the last time the two of you had sex. What happened?
Just was kind of ordinary.
So ordinary, like because you were in the bedroom, it was morning or afternoon? Give me a little context. Where are you guys? Are you at his place, your place?
Well, we live together,
Uh-huh.
and you know, she's been kind of depressed lately, and it's hard for me to approach her, but we finally decided, and she didn't seem into it that much, and I just don't know what to do. I think of this other woman, and I feel so guilty.
So have you ever tried having sex with your partner, since she's a little depressed and not that in the mood right now, while you're having a fantasy about this other woman?
Because it's not working.
Well, when you say it's not working, you mean it's not as exciting as you'd like it to be. Yeah, it doesn't sound very exciting. How often are you having sex together?
Maybe once a week, every other week.
And how frequently are you masturbating? You get the idea. I'm digging in. You know, I'm not taking this like, you know, fluff of like, I don't know, it's not so great, you know, because it's so easy to be sympathetic to that because, you know, it happens to everybody, or at least many, many people, high frequency. And yet, the devil's in the details. If you don't dig down and find out what's going on. I mean, it could be any number of things. The woman could be depressed. She could not be, you know, maybe she's not into him. Maybe he was with her because he had other reasons for being with her, and now he's kind of getting a little bit bored, and we have this exciting new person, and maybe they should be together. I mean, who knows? You need a lot more information. And depending, I guess part of what I want to get to with your patient, if I were in your shoes, is this something he wants to work on with this woman? Is there enough positive in the relationship that if this problem was fixed, he'd really like to be able to continue the relationship?
He said yes.
Great. So then what I'd like to do is refer the two of you. Would she be willing to get some help? Does she also believe that this would be better? If your relationship would be better, sex would be better?
Yes, I think so.
That'd be great. Because then, like Bruce referred to that sex therapist who was able to make a difference, I would say, you know, that's something you want to do. And in fact, let me just talk about when to refer for a moment. So number one, if your patient requests it, it's a good idea to refer after you explore why they want to do that. What I tell the physicians is frequently medication and just a little bit of education, you know, they hand out these little flyers, is really not going to be sufficient. And yet, for you, identifying psychological issues doesn't necessarily mean you have to be the one to treat them. So you want to practice to your own comfort level. And here's just a little model of how you might be able to do that. So if you're a physician, sex coach, a urologist, and you want to take the time, you frequently are going to be able to help somebody who's got mild psychosocial obstacles. But you're really going to need some other people helping you if things get more severe. And even, you know, as therapists, you have a skill set, an armamentarium, a toolbox, and sex therapy may not be particularly broadly based within your toolbox. In which case, making that referral, if that's something that you want, and then being able to work along with that sex therapist, it doesn't necessarily mean that you have to terminate your treatment. In fact, I like it when somebody's seeing someone else individually because it takes some of the pressure off of me to have to sort of capture and rescue if they do break up. So if she had a therapist and he has a therapist and they're both talking to me, I actually feel a lot safer working more rapidly because I know there's somebody there to kind of catch them if they fall. Any other questions? Yes?
Earlier in the case that you were
Can you try to
describing,
use the microphone? I think if you activate it, it'll work.
in the case that you were describing earlier, you mentioned that you always saw the woman first. I was wondering if you could go into more detail about that.
Oh yeah, that's a great question. Thank you for reminding me. The reason I saw her first was her vulnerability. I knew that if I spoke to him and he gave me one side of the story and she really disagreed, it would really affect the rapport that I had with her and her trust on me, especially because I'm a man and she'd been abused by a man. So I wanted her to feel safe, and it gave me a heads up as to what the issues were. In addition, she was more insightful and psychologically oriented than he was. So, you know, it was like a cheat sheet. You know, I'd know what I was going to hear from him, and I'd have some ideas of where I wanted to go with a conjoined session before I even started. So it was one, to help her feel safer. Two, it gave me just an easier path to success. And three, he was a more compliant guy. So I knew he was the one that if I needed to keep somebody waiting, he'd be totally okay with it. So some of the sessions with her were quicker, and some were a little bit longer, like when she started telling me about what went on with her and her father. He only got 10 minutes, and she got 40 that day. Yes?
Can you describe the vaginal dilators in more detail,
Sure.
like how they're used and also if there are any complications in using them to look
Sure.
out for?
Yeah, I mean, generally speaking, if people aren't going into a sex shop and buying, an array of like large-size vibrators, the complication rate's very little. This is medical-grade silicone. Some of them are a little harder, some of them are a little bit softer. The gynecologists actually are now very familiar with using this as a treatment for vaginismus. Vaginismus is when there's, a contraction at the vaginal opening and the woman is not able to allow penetration. And most gynecologists will diagnose that because they can't do a pelvic. They'll have to use like a child speculum to be able to open her up enough to do a pap smear. So it leads, a decent gynecologist at least, it leads to a conversation where this can happen. And frequently nurse practitioners in the gynecologist's office will get someone started in helping them with this. And, basically, they start out very small where it's almost pinky size, and then it goes up to something that's about 3 fingers, at least 3 of these fingers.
And would they be like inserted into the vagina and then left there all day, or is
Oh,
it?
no, that's a great question. I'm glad you asked. She would insert it, and I have people use them differently. One of the things that I used to do when they were more plastic, what was available now, there's a higher grade of silicone-based vibrators available. But when they were a little harder and waterproof, I would have a woman use it in the bathtub because the hot water would help physically relax her, just in general, so there was a little less anxiety. And I will talk to somebody, this, again, it really depends on the patient's values and cultural background. Certainly some women will insert a small one, self-stimulate their clitoris, get themselves more aroused, and then start putting in the larger ones. Basically, you want to maintain it intravaginally for at least 10 to 15 minutes, but certainly not all day. And for the patient, towards the end, right before they terminated, as I mentioned, she was having sexual fantasies, and she said to me, like, I'm sticking something inside me, it's exciting. I come every time I do it. In fact, I began to be concerned that I may need her to not do that because her frequency of orgasm with the dilators was getting so high, I thought it might diminish some of her interest in having sex with him. But they were both so excited about this sort of renewal of their sexuality that it wasn't a problem. Anything else before we, yes, please.
I have a client with a lot of complicated issues, sexual assault, loss of a parent at a very young age, and 18 years of substance abuse. So she's,
What type of substance?
Virtually everything, meth, cocaine, you name it, and
Lucky you.
I'm sorry.
Lucky you.
She's
Sounds
off.
like
She is off of everything.
Oh, great.
She wants
How
desperately.
did she get off, by the way? Explain to us.
She came in with such motivation. I had her see our psychiatrist, who explained to her to go on Wellbutrin and to help her with her libido because she had no libido. She felt she had no libido, but she had to be off of everything. She just said, "I'm stopping," and it was.
She said, "I'm what? I'm sorry."
I'm going to stop. I'm not drinking anymore. No cocaine anymore. It's been miraculous to me. I mean, this has gone on now for 6 weeks. So. But I'm wondering if the history of substance abuse could have had a compounding effect on the problems that she's having.
Well, no doubt. We talked about those switches getting changed over time. If you're firing those dopamine receptors so continuously, the likelihood that, at least temporarily, nobody really knows how permanent this is or isn't. But I've certainly seen that a lot with people who stop all drug usage and then find that nothing is really all that exciting to them anymore. It's as if they're quote unquote burnt out. That said, somebody who's as motivated as your patient, I'd be interested in finding out, for instance, like, is she masturbating at all? And if she is she able to have an orgasm? At what frequency? What might you be able to suggest from the way of fantasy or porno or erotica to help her have an even more intense experience? Because now we know what her limitation is, right? If it's a dopamine problem that's physiological, then that's not going to change from day to day. So if there's something she can watch or read that helps turn her on, and the kind of stimulation helps turn her on within the context that works for her, now we know what her limitation is. Now, is she able to experience that when she's with a partner? If she's not, now let's take a look at what are the obstacles, those immediate causes that are getting in the way of her having the same experience with a partner that she has by herself. For most people, it's the self-consciousness, of course, of like thinking about this other person and getting distracted and really not knowing how to fully integrate the experience. But go ahead, you have your light on.
Well, what's further complicated is while there was a single instance of sexual molestation by the stepfather after the death of her mother, she has a very, very strong need for control. And she talks about that a lot, which, so we've talked about masturbating, which, she's getting vibrators, et cetera, and she's going, gonna go on the Wellbutrin. And we've talked about her thoughts as this is all happening. She hates being, the second that she's touched, that's when.
Well, is that evoking a memory from what happened
And
with the father?
she says she denies that. I didn't directly ask her because I didn't want to put it in her head. I said, what are the thoughts going through your head?
Sure. But I would
And-
tell you, what's the risk of asking that question?
So that's my
given
next,
what you-
I've been trying to pull it out of her, and
Sure.
that's my next step is
I
to
just,
directly
so
ask
you
her.
don't, you don't have to work quite so hard. I might just suggest to her, I've been thinking about, in fact, if you just say, I went to a lecture and got me thinking about your situation, and I'm just wondering if you could explain a little more to me about what's going on in your mind. If you're reading something sexy, do you find yourself distracted and getting off of it? It's like meditation, right? If you're trying to teach somebody meditation, or even like a relaxation technique, if you're doing more traditional behavioral therapy, as a for instance, many people will say, I can't concentrate, I can't relax, And you find out what it is that's keeping them from being able to be in the moment, and you need to find some kind of catch that will hook them to be able to either focus on their breathing or use a muscle relaxation technique or a meditative technique. And, not to sound like a Buddhist, but, clearly this notion of being able to foreground background and allow things to sort of float by as you are concentrating on something is a skill. And my hunch is, based on what you're saying, that's a skill that would be useful for her regardless.
Yeah, she, and she is meditating, she meditates regularly.
Great.
So
how does she meditate on sex?
Meditate on sex?
Yeah. How does she get her mind really focused on everything that turns
She
her on
doesn't
that's
want,
really
well,
erotic?
this is the problem, she doesn't want to think about sex at all.
Right.
That's the, that's what, yeah.
Yeah, then I would be I'm as confused as you must be, because then why would we even be talking about this with her if that's not the focus for her at this point in time?
She's very hopeful that using Wellbutrin, using erotica, pornography, and if her boyfriend, if their relationship improves, that the combination of all these things, masturbating, that she is going to get to the point where she's going to want to have sex.
So kind of behave yourself into a different way of thinking and
Yeah.
feeling. It's possible. Let me offer a cautionary tale about Wellbutrin. I've certainly seen Wellbutrin make a difference with people, but the main advantage of Wellbutrin is it's a sort of mediocre, not particularly strong antidepressant. So it has less side effects. So it's not that it's pro-sexual, it's a double negative. It's not as anti-sexual as some of the other drugs. So frequently, if somebody's on a high dose of an SSRI and you need to reduce it, but you don't want them falling into depression, you might augment with Wellbutrin and reduce some of the SSRI in the hope that it hits a threshold that is sort of good enough to, going back to my tipping point model, to sort of tip the balance and allow it to happen. The one thing I would avoid doing with this patient that I think most of us might be at risk for is getting overwhelmed with all the different cross currents that are there. And, I might, depending on my relationship with her, stick with the masturbation initially and see if we can enhance that experience before we try and enhance everything else. We can't control what your boyfriend's going to do one way or the other, or how he's thinking and feeling. We can control the situation that you put yourself in, where you decide to stimulate yourself and you decide what kind of erotica you want. And let's see if that makes a just noticeable difference. And then we can reevaluate next week. That type of thing.
Thank you.
Yes.
Have you developed a model similar to this one for women's sexual dysfunction?
It is for women as well as men, absolutely.
Just like
Exactly the same.
exactly the same.
Exactly the same thing. It all works the same way. The differences between men and women are negligible compared to the similarities. If you take a look at two bell-shaped curves, right? There is a difference between men and women, but there is a difference between the mean of those two bell-shaped curves. I don't want to bother to look it up, but I've got a slide that shows this. So you've got a difference between these two means, but the area under the curves, the amount of overlap, is actually something like 70%. It's huge. It's huge. So, yeah, you can say, well, you know, she's got a vagina and I've got a penis, so how can you say it's the same? Because what causes penile erection is vasoaction in response to stimulation, both central in the brain and friction. And it's the same thing for a woman. What causes lubrication is blood flowing to the area, creating, you know, warmth and a transudate that causes lubrication. Exact same phenomenon. And, you know, if you look at sort of even embryonically in terms of the tissue, you know, the penis and the clitoris are derived from the same tissue. There's just tremendous overlap. I don't go so far as like some of my colleagues where I start talking about the female prostate because the Skene's gland can release some fluid, and isn't that the same thing as a prostate? I think there's a benefit to using traditional terms to describe things because people at least know what you're talking about. But the reality is the similarity is huge. You know, she's feeling pain. That pain is blocking from that sexual tipping point model. The pain is blocking her ability to be sexual. He's feeling anxious about not pleasing her. He's not getting enough friction. That's at a very simple, immediate level. But the model is the same for both. Please.
That, and this is a naive comment, Viagra and Cialis and the rest are confidence booster for men. What is the booster for women?
It's a confidence booster for men only because you're seeing the visual erection and you're able to function. The main problem for most women, if you look at the frequency of complaints, is a diminished desire and arousal. That's both a subjective phenomenon, which is taking place in the brain centrally, as well as a physical phenomenon in terms of lack of lubrication, lack of vaginal swelling. So if your question is there a pharmaceutical that would have the same kind of impact on a woman that a Viagra, Levitra, Cialis might on a man? The answer is yes and no. Flubanserin, which just got approved by the FDA the year before, it's under the trade name ADA. You wouldn't know much about it yet because the FDA put a limitation on their ability to advertise. That will be lifted shortly, and you will hear more about that drug. That's a centrally acting drug, so it's going to affect her desire, and by increasing desire, you're going to have increased arousal. But one has to do with blood flow, the other has to do with neurochemistry. Viagra, Levitra, Cialis will give a woman a bigger clitoris. It's just, I've never had a woman complain to me that my clit's too small. So a guy is going to have a reaction to that increased vasocongestion, that erection, that most women don't have. The subjective component is going to be more important to most women. Now, I did say, though, that aren't men and women more similar than they are different. If you look at older guys, or the men who are not Viagra non-responders, they're remarkably similar in what they have to say to women who are also not feeling what they'd like to feel. So it depends.
No, I guess I was thinking a patient I had.
Yes, please.
She had no issue with desire.
Uh-huh.
She just couldn't orgasm.
Well, that's
At
actually...
the point, I mean, there was something that inhibited
That blocked it.
the huge
Perfect.
blockage.
Perfect.
And she solved it for 3 years, let's say, and then it came back.
So when
And
she
her whole
solved
life
it,
has
what,
been,
yes, when she solved it, what changed?
but she was able.
No, I know she was able to have an orgasm, but do we
What-
know what else changed that correlated with that increased orgasmic capacity?
Everything. I mean, it was in general, you mean it was like her main thing.
See, and I would say,
Life.
not in general, I would say, what were her thoughts? Were the thoughts different? Was the quality of the stimulation different? Was there a change in some way?
Well, yes.
What was the
That's a very
change?
good question, yes.
Thank you.
She was able to orgasm when she was in control. in certain positions where she was uncontrolled.
See, but I would tell you that that's actually very common. There's a lot of women who can only orgasm a particular way. You know, I get manicures periodically, so I'm in the nail salon. You know, and the nail salon is being like in a woman's locker room. You know, if you're listening to what's going on, he never hits the right spot. You just can't find it. The right spot is how she's learned to have an orgasm. Whether that was the first boyfriend who touched her in a particular way, or how she self-stimulates. So what I talk about with patients who are having that experience is how to take this porthole and turn it into a picture window, so that they're able to be responsive to a wider variety of stimulation. Same for men. We talked about my patient that had a delayed ejaculation and he wasn't able to come when his wife gave him a hand job. Most men can come if a pretty woman is stimulating their penis and rubbing it up and down, but not all men. He had the exact same problem, but he was able to come during intercourse because psychologically it was more exciting for him, and he was getting more friction. Because the way he masturbated was much rougher than what she was doing, and he was too shy to tell her. So part of the therapy, I mean, I didn't mention this when we were talking before, but part of the therapy was to get her to be more vigorous. But as he said, in a very particular way, he wanted certain light, slow touching towards the bottom, and then as he got more excited, he wanted it more rapid at the top. It was pretty specific. Now, I would say that degree of specificity has its own problems attached to it. But my feeling is when they're happy, I'm happy. And you have to know when to leave well enough alone. I'm actually going to need to stop now. Thank you all very much.